For those of you just joining us, welcome. We'll be getting started in just a minute. We're watching the numbers rise as the people walk through the virtual doors to join us for this very special event. The room is continuing to fill. And we're certainly glad you're able to join us. We'll be getting started in just a moment. All right, let's go ahead and get started. Welcome, everyone. My name is M.P.H. I'm Dean of the Larner College of Medicine, and I'm delighted to welcome you today for this first interview that I'm getting to have with Dr. Jan Carney, my close colleague, for now the fourth edition of Off the Charts, a periodic Zoom webinar series in which we showcase important work going on at our institution. All of you watching today will be a part of this event in that you have the opportunity to ask questions that we'll be answering at the end of today's session. You'll notice there's a Q&A tool on your Zoom screen, and you can post questions anytime during this webinar, and we will address those at the end of the session. Among those watching today, I know there are many alumni from our college in the audience. We're so fortunate to have such dedicated alumni here. Individuals that are dedicated to their patients, dedicated to biomedical science, and to this place where your careers began. Your engagement is inspiring, and your support for the work going on here today is vital to our missions of educating the next generation of physicians and scientists, improving patients' lives. Improving lives has been the focus of Dr. Jan Carney's career throughout a number of decades. Dr. Carney is professor of medicine, associate dean for public health and health policy for the Larner College of Medicine, and a member of my senior advisory group. She holds an MD degree from the University of Cincinnati College of Medicine and completed an internal medicine residency at the former Medical Center Hospital of Vermont, now UVM Medical Center, where she also served as chief medical resident. She was appointed to the UVM clinical faculty in 1985, and in 1987 earned a master's degree in public health from the Harvard School of Public Health. She was named Associate Dean for Public Health at our institution in 1999. Dr. Carney served as Deputy Commissioner for the Vermont Department of Health from 1988 to 1989, initially as Deputy, and then as Commissioner for the Department of Health from 1989 until 2003, under three different governors, Madeline Kunin, Richard Snelling, and Howard Dean. During her 13-year tenure as the state's Commissioner of Health, she championed improvements in such areas as children's health, health insurance, teen smoking prevention, and cancer screening. She's received too many awards to list here today, but among them are the Vermont Medical Society's Distinguished Teaching Award, the highest honor that society bestows on one of its members for meritorious service in the science and art of medicine. She was also honored as a local legend by the National Institutes of Health, National Library of Medicine, and the American Medical Women's Association. She received the Vermont Public Health Association Public Health Champion Award in 2018, and in 2020 was awarded UVM President's Distinguished University Citizen and Service Award for her innovative teaching, creative leadership, service to the UVM community, and especially during the time of COVID, where she was such a valuable and trusted voice. Dr. Carney is active in public health practice, research, education, and service. She's a master of the American College of Physicians, a fellow of the Royal College of Physicians, and has authored many scientific books and papers. She developed Vermont's first Master of Public Health degree and other graduate level public health programs, all online. And she directs the Rural Health Research and Delivery Corps for the Northern New England clinical and translational research network, working to engage clinicians, communities, and public health advocates in the development of research relevant to rural health needs. Nationally, she serves as vice chair of the American College of Physicians Health and Public Policy Committee, contributing to the public health policy publication in areas of social determinants of health, health insurance coverage, and patient partnership in health care. At UVM, Dr. Carney was instrumental in leading our college to a successful LCME accreditation in 2013 and again after my arrival in 2021. Personally, Dr. Carney has been a valued advisor to me and leader to the college, university, and region as we address the COVID pandemic. Dr. Carney, Jan, that's quite a mouthful. You've done so much for our region, for our college, for our university. Your focus has been in public health. What first attracted you to public health?
Well, when I was actually in elementary school, I discovered I wanted to be a physician, and I had a teacher who influenced me in that regard. And then after I went all the way through medical school and residency, became an internal medicine specialist, I realized that the patients I was taking care of were very ill or dying of conditions that were at least in part preventable. And one thing led to another, and I ended up going to public health school. And at that point, I learned that there was a whole science of prevention for patients and entire populations. And that was kind of the turning point for me. And then I came back and I looked for opportunities while seeing patients, opportunities to get more involved in public health, and then began my work with the Department of Health.
So you and I are colleague internists, and it's interesting how our lives' directions go and what really stimulates us once we've gotten that core training. Thinking back to my own medical school, we learned about disease, we learned about treatment of disease, and we took all of the medical problems almost as a given. And it's somewhat humbling to realize that plumbing saves more lives than medicine, perhaps, in terms of the public health, the underpinnings of the health of society. How are we doing in terms of educating our medical students in the importance of public health, in addition to treating disease, identifying disease, preventing disease? What are we doing at the Larner College of Medicine?
Well, I think that in general, we're doing a lot better than we were in medical school, when most of us might have had a session or two in epidemiology. But now we fully embrace the relationship and the close working relationship between taking care of individual patients and communities or entire populations. And here at the Larner College of Medicine, we've been doing this now for, I think we're going on 20 years, where we've more formally integrated that. And I can speak to a little bit about my work. I get to talk with our medical students right when they come in the door, pretty much in the first couple of weeks. And I talk to them about, how do you think about, or what metrics do you use to determine if a community is healthy? You're going to learn all about how you determine if a patient is healthy and how to keep them that way. But how do you learn about that? And it looks at, there's a variety of national metrics to do that. So we talk about that. We talk a little bit about health systems, because more and more our health systems are configured in a way that we really need to think about taking care of individual patients in the context of entire populations. And those populations could be in a town or county. Sometimes they could be in an entire state or region. So that role of populations is really important. So they get that right off in their first year. In the spring of their first year, something we've been doing now, and this will be the, I can't believe it, 20th year this spring, is we have a longstanding community academic partnership. And it started back with the United Way of Northwest Vermont, but it really started because the students were asking for a way to make a difference in the community over time. So what that told me was that we need to think about something that will engage them and engage entire communities and organizations to work together with us over a longer period of time. So what it looks like, and it's just called public health projects. It's a required course. It's a 1-credit course, and they do that while they're doing all their other essential sciences of the first year. And the community organizations, we have relationships with probably 100 to 200 not-for-profit organizations, submit proposals for projects from our students. And every year there's 16 projects, and students work in groups to try and come up with how to get the communities more a solution to the problem, more information, something that they can give back to them in the form of a poster. And we have a big poster session at the end to do that. It's hard, it's ambiguous. These are enduring public health problems, mental health, things related to housing and social determinants of health. But the students, they struggle for the first few weeks, and then they really embrace that and give back something to our community organizations that have made them want to come back year after year after year, requesting to work with our students.
You know, as I've gone around and visited the posters that the students with pride are standing by, it really is inspiring, and it's a beautiful synergy in that we're part of this community, and consistent with our land grant mission here at the University of Vermont, we need to be serving our communities, and to see the enthusiasm of the students, to talk with some of the representatives from the different groups that the United Way helps bring together. It's really exciting. Med school's hard already.
Right.
I'm interested in whether there was any pushback in the early days to adding another project, either from student or both, from the initial student response and the response from the other educators in trying to get all this information to our students in the limited time we have with them.
Always. There's never enough time to work with the students and teach and learn everything we need. But the world is changing, and the health issues that we're facing are broad and complex and really relate to some of the social needs and the social factors that determine people's health, like do they have enough food? What's high quality food? Are they able to be physically active? What about their health habits and behaviors? Do they have access to primary care? And we know in our rural parts of our state, that's particularly challenging. And my simple goal was, first of all, to be a little persistent and work with my colleagues. And we figured out how to give just a little bit of protected time. And with a little bit of protected time and a group of 6 students and 18 or 19 weeks in the curriculum, you can do a lot. So my simple goal was, and I tell this to students, and I have examples of this, is my simple goal was to get them out of the building. Because when we see patients, we see them in a clinic, in an office, in a hospital. We see them out of context. We see them out of the context of their house or neighborhood or apartment and social supports, what they're eating, what they're doing, what they like to do, and them, everything about their lives. So when the students would go out in the communities, all I want them to do is get out of the building and see the experience of some of these different agencies, that everything from the health department to some of the housing agencies and the agencies that work with adults with intellectual disabilities, lots of different agencies, just to have that in their frame of reference when they come back and see patients. One of the examples in the early years of the course was that the students went out to one of our neighboring towns called Winooski, and their project was for the YMCA to go door to door and get a sense of what people needed in terms of physical activities for people in the community, nutrition support, those kinds of things. What the students came back and talked about was the variability of housing quality they saw depending which neighborhoods they were in. And that surprised them. So that was exactly it. That's what I wanted them to see, to just be out and see that that when we see patients and we're doing everything we can to figure out either what's wrong or keep them healthy and support them in their health and illness, that we have to remember all of those other factors that are really, really essential to their health and do what we can. And sometimes we're much more conscious about this now in healthcare settings as we're seeing patients. But in some cases, it takes advocacy to make that better for groups of patients and entire communities, and just wanting them to be conscious about that.
Yeah. You know, you talk about your persistence, and I think you're known for that. And I wonder whether your experience in public office played a role in that.
Oh, yes. Yes, absolutely. And I think what I learned, I can't say enough about my time working in the Department of Health, positive. And both, you know, we saw that more recently in the pandemic, the people working at all different kinds of activities in public health, everything from the laboratory, the epidemiologists, to people doing public education. But we're very fortunate in Vermont to have people who are so dedicated. I learned that right away when I worked in the government, and the politics. I was terrified, and then I learned over time that that people who are in our legislature, our governor's staff, people in local leadership, all want the same thing that we do. And we have to develop relationships and do everything we can to work together with them.
Yep. And you certainly have brought that perspective to our college and the university effectively. Now, the fact that you developed a now nationally accredited program to give a degree, a master's in public health, completely online. It's almost we'll talk more about COVID in a moment, but pre-COVID, you had this vision and made this happen. Can you talk about how you put together a program and now a well-regarded program in public health here at UVM?
Well, first, when I was at the Department of Health, I heard for years that everyone wished that we had a Master of Public Health program at UVM or something right here in Vermont, because to further develop their education, and a lot of people working and practicing in public health may not at the start of their career have that credential and the most recognized credential. So that kind of stuck with me. And then when I came here, we continued to hear that and heard it from faculty and students and people in the community I work with. So I developed a partnership with continuing distance education here at UVM. They're now called PACE, and they were wonderful, creative.
PACE stands for
Professional and Continuing Education.
Right.
Yes. And they did at that time a lot of the distance education, and said, maybe we should think about developing some courses, and maybe that might be a way to actually do this. And so, long story short, I developed my first course online with sort of the thinking of, if I can do it, all my faculty I work with can do it. And so that's what we did. It grew. We first built a 100% online graduate certificate, half the M.P.H. And we did it because students were asking for that. Some students want to go through straight into their entire master's degree. Other people are working and want to do it more part-time. And while they're working in healthcare, all different kinds of professions. And so it was more flexible and versatile. And so we prioritize ways, working with continuing distance education, have innovative curriculum. We built that. We had a lot of students enroll. And so we went on and built the master's degree 100% online. And that was in 2014. And we built it, and they came, and they still are. And that's awesome.
Yeah. And talk about the process to get accredited. You could give an M.P.H degree,
right?
But in the last, 2 or 3 years, you've achieved national accreditation. Can you just comment on that and comment on what's the difference between a program in public health and a school of public health.
Program, the accreditation is like the national seal of quality. You know, in medical education, we have the Liaison Committee on Medical Education, LCME,
Yeah.
and we all do that. And so that's something for the public that they know. For every medical school has to have certain quality features that are regularly monitored. In public health, it's the Council on Education for Public Health, and that's the CEPH, and that's the national body. So when we're looking at this, and both you can be accredited as a program or a school, and the difference is may just be around size, and you can, what you must do is offer the courses, the number of credits, and the distribution, and have the systems in place to assure that your courses are of high quality, your students are learning, your students are getting the support services they need. You are making sure that your students are well prepared for their careers, and that it's a system of ongoing quality. So yes, we did that, and actually during the pandemic, and we're delighted and very proud of that.
As I recall, we were interviewed online.
Yes.
Just as our LCME
Yeah.
accreditation was online,
Yeah.
and high stakes, and congratulations again on that achievement. Now back to public health in this wonderful rural state in which we live. There are challenges in terms of access, in terms of generational poverty. We have new Americans arriving, and there are disparities that have been exposed, especially in the setting of COVID. What are we doing here in terms of studying rural health and addressing healthcare disparities? And finally, promoting community engagement, because if nothing else, I've learned that for the university to go and tell people how it is, that's not how you change minds and make people better. You need to go and listen and find out what the issues are. How have you addressed, and how will we address the challenges we have here in the state of Vermont and beyond?
First, this is one of the toughest ones, in my opinion, and it's one of the things I would say are enduring challenges, and we've done a lot more in the last 5 years. But first, let me speak about what some of those disparities might look like. And an example might be, a more recent example might be in the area of cancer prevention, for example. Let me just use that as an example. During the pandemic, when people had delays in healthcare initially, and then we discovered telehealth, which was one of the bright spots, but people delayed some of their cancer screenings. When we look at that across the board about what that looks like, what are those rural urban differences in cancer prevention and mortality and incidence? And people in rural areas, because of less access to care, sometimes there's definitely transportation, economic challenges, differences on the average in education, for example, differences in cancer mortality. If you live in a rural area, there may be differences in tobacco-related cancer occurrence because of differences in smoking rates, as an example, and access to screening services that we know, effective screening services, everything from mammography and colonoscopy, colon cancer screening, and now lung cancer screening. So serious differences there. And if you think about those outcomes, are there things that we can do? Absolutely. And there's this whole evidence base that one of the things we're working on now is how do we get that more out in not only the common knowledge, the common action around healthcare and public health. As an example, some of the evidence base to get people into screening relates to more work on health literacy. And that's an area of focus. It's around community health workers. These are non-physicians, non-nurses who work with doctors and nurses and health systems and practices and community organizations to make those links into those. The big thing that we've done in the last 5 years is our Northern New England Clinical and Translational Research Network. And that has been, we're now in year 6 of that. We got a renewal, and it is a partnership with Maine, and now also with New Hampshire. And the idea, and we've been focusing greatly on improving things in rural areas. The focus is on how do we have more research that's practical, research that's done, for example, in physician offices and with community organizations. So that's been a real focus to figure out, and that's why it's called translational. How can we take the science that we know and figure out ways to put that into practice in our rural communities? Very tough. We're working on that a great deal.
Yeah, and I know you've really stepped up, and are key to the renewal for the Northern New England CTR, as we call it, that large grant focusing on rural medicine, healthcare disparities. You mentioned the Cancer Center, and as you know, this is a priority for our college, fitting very well with our three missions of clinical care, education, and research, plus community outreach. And that, as you know, we look forward to eventual NCI designation. Randy Holcomb is leading that, and public health efforts and reaching out the community and the education that you're talking about in the community, and meeting people where they are is so critically important. So we aren't through with the pandemic. As a public health specialist, I don't imagine, I know you were preparing, or at least aware of the possibility we could have something like the flu of a century ago, but we're not out, but we're on the other side, and we've learned so much. And again, I'd like to state how valuable your voice has been to me and the college and the university and the region. What have we learned from COVID, and where do you think we are these days?
I don't think we're out of it yet. I mean, I'm not one of the ones that says the pandemic is over. We're watching carefully. I think where we are is we are trying to get, for example, one of the most extraordinary scientific accomplishments that I've ever seen in terms of that vaccine development and rollout of safe and effective vaccines. So right now, for example, the national focus is on trying to get people boosted, right? And much lower percentage than should be, maybe across the country, here in Vermont, maybe less than a third. And what does that do? That protects people. It may not protect them 100% from the illness, and particularly as we get these new variants, but it protects them from severe illness and being in the hospital, and is very effective in that regard. So I would say that continuing to figure out ways to reach people who are tired of this, and reach people with that message, and making that more accessible. I think that's really important. I think that the ability to not forget, and some of the things I think were most noticeable to me during the pandemic was that it's so hard to be prepared for the future. You kind of know intellectually that this could happen, but no, it won't really. And we'll do something, but it's okay. We can wait. Well, we can't. 60% of the infections that we see in infectious diseases are from zoonotic diseases. Public health is global. So I hope that we take stock of the fact that we need to be thinking about preparedness all the time, for the future. And that to take those areas where we saw gaps and to really strengthen our public health system. And I don't just mean the government public health system. I mean the connection of public health to healthcare and community organizations, and all the people have to work together for public health. That would be one area I hope we don't forget. Healthcare, we don't have access to healthcare for all of our people here in the United States. And that's something, when I work on the American College of Physicians, and I spend a lot of time working with them, that's my national organization that I do a lot of work with in the advocacy, to try and figure out ways to get more and more people have health insurance coverage, and then get access to healthcare, which means making sure that we have enough physicians in primary care, for example, and all the different specialties in our communities. I think we learned very clearly and saw what we're calling social and structural determinants of health, the impact of that structural racism, and the historical repercussions of that to this day, and making that better. Looking at health by zip code. Health code, zip code is a bigger predictor of our health than the genetic code. So how can we focus on engaging communities? And we talked earlier about community engagement, but that's why it's so important, because in every community, we have leaders and organizations who can help bring that information and help people get access to health and social services. So those are the general areas that I hope that we don't forget and that we continue to move forward on.
Thank you for that. And it's really remarkable, the social determinants of health. And I like that expression, that the zip code plays a greater role than the genetic code. And I'm thinking about that, and that's absolutely right. The pandemics used to be something that seemed like they were in the history books or geographically distinct from here in the United States. Think Ebola. I just recently saw that that the latest outbreak of Ebola was officially called as under control or quelled for now. Do you see other diseases on the horizon? There was a time going on 10 years ago that it looked like Ebola might take off here in the United States. And I know, actually, I'll make note that faculty from our own college went out to Africa to in the setting of that. So there was a fire and they were running to the fire, as physicians are known to do. What do you see in terms of other potential pandemic illnesses that might be on the horizon?
I guess going back, there was a time like in the 60s where we thought infections were under control. We were done. We had antibiotics, everything was better. That was not correct. And we had all these new and emerging infections. And part of it was back then was there were new forms of old diseases. People had let down their public health infrastructure, their surveillance systems to look at that. I think we're in a similar place now. One of the things I think about often is the concept of One Health, which is really the intersection between the impact of the environment, zoonotic and veterinary medicine, and medicine public health. And so, and I mentioned that sort of statistic that maybe 60% of infectious disease and new and emerging infections might relate to zoonotic diseases.
And define zoonotic.
These are diseases that might be in animals that can also potentially spread to humans. And in our public health faculty, we have 2 public health veterinarians working on parts of our curriculum. So this is an area that has a lot more prominence, in my opinion. Also, if we think about climate science and the changes in climate and what might happen at all levels of the ecosystem with changes in temperature, so what does that do to different vectors? You can see that one of the examples might be the changes in the expansion of Lyme disease in the Northeast in recent years. So I think I just go back to the fundamentals. Public health is about counting and surveillance systems and monitoring this and making sure that we're doing that and that we're investing in that and we're doing it globally. And we have this great relationships with all the global nations so that we know if there's a problem, and that we have strategies in place for when there is a new infectious disease. I don't know I'm not going to predict what that might be, but we know that there will be. So figuring out the science of prevention, and then that will really depend on what that is, but making sure we have the public health systems in place, and those heavily rely on, for example, with this pandemic, understanding the genomics of this and the variants and what does that mean, and how nervous should we be? And should we continue to try and advance our vaccines for some new strategies for that? I don't know what the future will bring. What I do know is we need to be better prepared than we've been in the past.
Yeah. And, you know, I'm going to take us from looking forward to kind of looking back and looking at what was the present day in terms of infectious disease. And if you look in 1918, there are pictures of individuals wearing masks, and that was the flu. The statistic, I believe, steady state, and you correct me if I'm wrong, but somewhere around 50,000 people were expected to die annually from each year's annual flu. Is that in the right ballpark? And we kind of took that for granted. One byproduct, and I credit you with emphasizing the fundamentals: masking, hand washing, distancing, being smart where you're getting into a large crowd, for example, especially in the early days of the pandemic. But a byproduct of the COVID pandemic is I've only had 2 colds in 3 years, and they were when I visited my grandkids who were coughing in my face, and I was sure I had COVID, and it's a cold. I haven't had the flu, and because we're wearing masks. There are some societies that were wearing masks more frequently, especially during the winter months already, without getting into politics of it, which unfortunately a mask is not a political statement. But in terms of wearing masks in and around, where do you see that going for our society in the current state and years to come, perhaps?
I think that we're trying to focus on health literacy. And if I had to think about one thing that we could contribute as physicians and in public health, to develop over time people's ability to find great and not misinformation on social media, but high quality evidence about what's the best thing for themselves and their families. I would say that's really, really important. So for masking, just use as an example, and I understand there has been some politics around that and related to, and that's part of, you know, people's view about our government. How much is our choice, and what is the role of government in health? And those have been the points of controversy. But if you think about people's risks and who might get more ill, it might be anyone with a chronic condition or people who are older. And certainly in Japan, they've been doing that for years. They just say, when there's a lot of contagion, to speak about it very simply, people might be more likely to amass in crowded spaces or in indoor spaces where that. So we might, you know, I think that's part of the educational process. The CDC actually has been talking about that for this winter, as we talked about the threat of lingering COVID-19 and influenza and RSV, particularly for kids, but something I think we're going to have to think about in the future. I think it's very challenging to this whole concept of what works and because it doesn't work 100% doesn't mean it doesn't work at all. So a flu shot, are the flu shots perfect? Nope. Should we get one? Yes, because they do help and they work more often than they don't. So when we don't get the flu and we get a flu shot every year, that really helps and helps us, you know, not spread it to other people, but just emphasizing the basics of the science that we know about prevention, and that's the clinical prevention and in doctors' offices, and also the community kind of prevention. But on a bigger scale, helping people to learn to find high quality health information that they can act on, and consult their physician or primary care practice when they need to.
Yeah, and to make both the personal decision and the decision as to what one's obligation is, perhaps, to the society around them. One thing that's humbling is that despite the fact I know you were been an athlete all your life, and we all exercise and try to stay in shape, but you can't fight the fact that your immune system changes over time.
Right. Exactly.
And if you look at the severe illness and mortality, it's pretty much a doubling or more every decade. So the
Right.
40s aren't as bad as the 50s, and the 50s to the 60s. And it's something we should just keep in mind in terms of making decisions about ourselves and others, and being careful and smart.
Yeah.
I've learned a lot from you, as I always do. I know there are questions online for us, and we're fortunate Dan Suter is here. For those of you who are watching, we have wonderful people who are supporting us in putting this together, and Dan is one who's looking for questions on the Q&A, and we received a couple in advance as well. For those of you who are watching this in real time, the Q&A button on your Zoom screen will allow you to ask a question. We'll do our best to address all of them. If we don't, we'll one way or another try to get back to you. But Dan, do you have a question for Dr. Carney?
Sure. Thank you, Dean Page. Just a quick note to our viewers, the Q&A function is not functioning right now, but questions can be submitted via the chat function to the hosts and panelists, and we can see it there.
Goodness. Well, we have people in the audience who can raise questions as well, right here in the room.
Exactly. The first question is about what efforts are being made to encourage students to go into primary care, and what are the obstacles?
Here at our college, we have a very strong emphasis on primary care. We have an office of primary care. We have an associate dean for primary care. We have longstanding statewide area health education programs. And we have actually been very successful in getting our students into primary care over the years as a high proportion of our graduating class. So I think we're doing extremely well. I also think that some of the challenges are, how do we get more physicians out into those rural areas? And they tend to be fragile over time. And so I think that that might be an area of continued focus for us.
Yeah, and I'll say that part of the mission for the Larner College of Medicine and UVM College of Medicine before we were renamed has been to serve our community,
Right.
and to serve our community in primary care is a critical mission for us. It's interesting, we do attract a number of students who want to go into primary care, or at least think they want to go into primary care. And many of them do. Sometimes they find something else that might attract them in terms of a different specialty. Likewise, we have a number of students who come in who are sure they want to be this specialty or that, and they're inspired by you or someone else in primary care, and that's the direction that they go. So we want our students to have opportunities to go in every direction. But as you say, I'm proud of the fact that we are populating the state and region with primary care physicians. We need primary care physicians. I will also mention we need cardiologists and even cardiac electrophysiologists. We need an array of specialty and primary care physicians to serve our region, and I'm proud that they get these excellent exposures really from the very beginning in terms of primary care practice regionally.
Thank you so much. There's a question about, is there more discussion about older adults currently happening within UVM's public health programs?
Yeah, the answer is yes. And there is in the college, we have a division of gerontology in the Department of Medicine. So a lot more focus on research in that regard. In our graduate public health program, we're also developing curricula in that area so that where are we seeing a lot of still preventable diseases? Yes. And as the population gets older, we can expect to see more diseases in our older population. And so that is part of the curricular discussions also.
Yeah. And certainly, you know, in my own clinical practices, as I see patients, it's a bit bimodal. I'll see some younger adults with supraventricular tachycardias and middle age with with atrial fibrillation, but many of the diseases that internists see in all specialties really skew toward our older population, and having our division of geriatrics and gerontology is critically important. All the while, geriatrics specialists can't care for all the older adults in the United States, and that's something that's critically important to acknowledge and prepare our physicians in all specialties, but especially in primary care, with the understanding that you will have a senior population, especially as your panel grows, and the geriatricians are tremendously important to give us advice in the more complicated situations. At the same time, we need to care for our seniors, and indeed, that's what most of us caring for patients are doing.
I might also mention a couple of things that are happening right now in the curriculum, in the first year curriculum in our students' public health projects. Our students are doing a project with Windham County in Vermont coalition, who is trying to forecast, given the aging of their population, how many health professionals and social service agencies and what kind of services they'll need as time goes on. I think that's very bold, and our students are helping them try and make some headway into motivating medical students and nursing students about practicing in these rural settings. So that would be one concrete example. And another example is there's an organization called SASH, Support and Services at Home. It's a statewide organization to provide social supports for senior populations throughout Vermont. And our students have been doing projects with them as well.
Yeah, the concept of continued home care is going to continue to be vitally important for our state. We don't have enough skilled or other nursing facility beds. We don't have enough hospital beds, and at the same time, seniors very often, if they have support either for themselves or loved ones who are looking out for them, or part-time caregivers, we can leave more people in their home where they want to be, and free up the beds that we need for those who truly need to be in a specialized facility. Dan, anybody else getting through to us?
There are some more
Wonderful.
questions. In addition to public health, people have been hearing a lot about population health.
Yeah.
Can you speak to the difference between population health and public health?
Sure. Some people use it interchangeably. And so when I work with a group of educators across the country. We talk about P.P.H, public and population health. And sometimes in healthcare settings, people use the word population health to mean population health management. So think about, we used to think about just individual independent practices. Now, if we have networks of healthcare offices that might include hospitals and other organizations, through the electronic health record, you can look at the services and the outcomes in entire groups of patients. So that concept of population health and looking at the entire population that's in that system that you're a part of can provide all kinds of opportunities. For example, pneumonia vaccines in adults, and those are recommended. So is everyone in your practice getting it? Are people getting their regular cancer screenings, as an example? Have they gotten their flu shot? So there's ways to really leverage preventive care and high quality care in a way using that electronic health record. So that's a lot of what we're talking about with population health.
Yeah. And that is truly distinct, isn't it? Because indeed, people do get confused. I think of population health as being responsible for a population, keeping them specifically healthy, free of disease or treating disease, and ideally in the alternative payment methods, being compensated not for when you make sick people better, but keeping a population healthy, distinct from the public health enterprise that underpins the health of the community. That's kind of how I simplistically see see the distinction.
It's exactly right.
Thank you very much. This is a COVID-specific question. What's the best time to get the bivalent booster after someone's had COVID? Should they wait 2 to 3 months after their symptoms first started?
First, my disclaimer that I'm not here through this presentation, your own personal physician. And I always encourage people.
And there may be new data.
And there may be
this online in a few months.
That's right. And
That's our
why the data may change. So I will speak to the recommendations through the CDC. If you go on their website, they say they advise about 3 months from when you had the illness. And part of that, and that's supported also by scientific literature that shows that in terms of the best time to really get the most out of your own immune system from that booster shot.
Right. And since we're on this, the bivalent booster, in the last week, I've seen new data out of Israel and other places that shows, I think it's in the mid 80% range for reduction in severe illness or disease relative to those who have been typically immunized in Israel, but not with that bivalent booster. Am I getting that correct?
Absolutely. Even as we see new variants all the time, the data is outstanding that getting that booster as soon as you can will protect you from severe illness and being in the hospital, for example.
So just about the only person who shouldn't have a bivalent booster is someone who's had the disease within 2 or 3 months.
Right.
But other than that, go out and get it. They are available. And frankly, we as a population are really not doing as well as many of our developed world peers and even less developed world peers in terms of getting those the boosters out there.
Yeah.
Thank you. Back to UVM, can you please share your thoughts about how the newly established Osher Center for Integrative Health at UVM will contribute to our medical education programs?
What a great question.
What?
Dr. Carney, you want to take that?
Sure. My answer is I don't know yet, but we are totally excited about all the possibilities. And this is really something new that has come up just in the last, six months or so. And looking at, again, the range of health information, health coaching, wellness, how to get people that education information at another center here. So we look forward to connecting with them.
Yeah, and integrative health has had a significant presence here at UVM for quite a while, with some leaders within our college and others outside of our college. And actually, Provost Patty Prelock led the grant to bring this Osher Center to, and there are just fewer than 10, I believe, at very distinguished institutions. So it's huge that the Osher Center is here. It's actually given me an idea for an off the charts, perhaps, sometime in the future, to discuss this and for us to learn and for us also us to inform about what the complementary and integrated health opportunities are, what we can learn, how we can teach, and what the opportunities are to integrate within our academic health sciences, including the College of Nursing and Health Sciences, and obviously the Larner College of Medicine. Thanks for that question.
All right. The next question, what are there specific policies or laws that need to be implemented or enforced to ensure public health authority in responding to crises?
Oh, wow.
That's yours, Dr. Carney.
That's a good one. I think you might get a different answer depending who you ask. And I think that, but that whole area of and in some states, public health authority has come under attack. Everything from childhood immunizations to not requiring anything or allowing anything in that regard. I'm hopeful that there will be more of a national conversation with many experts in different states and across our country about sort of the foundations for authority. I would go back to, I don't think necessarily that there'll be widespread agreement among our states. And I think we have to expect that. But I think that what we can do is shine a light on those models and those states that can result in the best collaboration across the spectrum that includes politics and healthcare and public health to provide the best outcomes for people. And I think that results matter, and results speak very loudly. I think that this whole concept of, in that conversation, if there can be some consensus around that, we really do need to be more prepared for the future. That would be the biggest thing that I could ask for right now.
Fair enough.
Thank you very much. Has there been an increase in the number of applicants to the Larner College of Medicine?
The answer is yes, and I'll try to get the numbers right. I think we were up to 6,000, and now I'm seeing, and then we went up to 9,000 in the last applicant pool. That has to do with a number of things. For one thing, I'm cheered by the fact that even in the setting of, again, to use the analogy of fire, young people are running toward the fire and want to be part of the solution. It also has to do with the fact that it's easier to apply online than it once was. That's 9,000 applicants. We have 124 in our entering class. Soon after I arrived, I visited with the fire marshal and was told we could go from 120 to 124 and not violate the rules within our learning rooms. We remain highly competitive, and there are a lot of potential good doctors out there. There are very limited spots still.
Thank you very much. That's all of the questions that we had.
And as a matter of fact, that's perfect timing. We've reached the end of our time together. Dr. Jan Carney, Jan, this has been fascinating. I always learn when I speak with you, and being able to just ask you questions has really been illuminating. So thank you for joining me, and for everyone who's joined us here for this fourth edition of Off the Charts. I want to thank you for joining us. I hope you learned something, and I hope this information will be valuable to you. I also want to thank the team that we have putting this together. It takes a village, and we would appreciate any feedback you have as to future topics, questions, or advice on how we can make our reach even greater in terms of the Larner community, our friends, and alumni. When we close, you're going to see a web address that will bring you to the Off the Charts website, where you can access previous editions, as well as get in touch with us if you still have questions or any advice. In the meantime, I look forward to seeing all of you at our next Off the Charts, as well as other events that occur here in Burlington with our Larner community. For those of you who are alumni, make plans for our next reunion for your class, and for opportunities to come by, say hello, and visit with us. Until then, again, Jan, thank you so much. And for everyone who's watching, please stay safe, stay well, and thanks for joining us today.